This is Brian Wormers recording number 3 in part 3 of Respiratory Dysfunction. We're going to cover slides 12 through 15, and the first thing we're going to cover is foreign body. As children are young, they often explore the world by putting things in their mouth. What does it taste like? What's the consistency of it? And all too often, this can lead into aspiration of a foreign body. These things can be a variety of different things, such as hot dogs or nuts, candy, carrots, batteries, buttons, toys, coins. There's a variety of different things that children can aspirate. The nice things that show up well on x-ray, think about metals, so coins and batteries and some buttons and some toys. The ones that are really hard to see would be the hot dogs and the nuts, especially like sunflower seeds. I've seen be really difficult because they're hard to pick up on an x-ray and you don't have definitive things. You can see that you've got decreased aeration to some of these lung parts and to some of these fields, but it's not as definitive as, say, seeing the coin in this picture. So a few things about this. With some of these things, think about those batteries that are flat and coin-shaped. Those are especially nasty for foreign bodies because not only can they occlude the airway, but they can also break down and leak battery acid, and that leads into, nasty chemical burns. But we can also get electrical burns. So if there's some secretions there in the fluid, can actually cause electrical arcing. So you can get electrical burns, chemical burns, and closing off that airway. In this picture, you can see the coin is vertical. In this position, I expect this patient to be doing fairly fine. Now, if you see this coin rotate and it's more of a horizontal picture, that's where it can get very dangerous in closing off the airway as a whole. So this one, I think the patient will be doing fine, probably not liking the coin in their airway, but it's much better than having this in the horizontal position like I talked about, and occluding the whole airway. So what do you do with this stuff? So if you're in an outside care provider and you're caring for a child that's aspirated something, of course you want to get them to a higher level of care in a place where they can do a bronchoscopy and pull whatever they aspirated out. In getting there, just remember your good old-fashioned CPR. So if they're coughing, gagging, sometimes you can use a Heimlich if it shifts and it occludes, and sometimes that will actually pop the material out. But just remember your basics of training, so airway, breathing, circulation, and good old-fashioned CPR, using the Heimlich or using your back blows and your abdominal thrusts for little kids. If you get advanced skills, sometimes we will put down ET tubes, so a breathing tube, and we can actually push this down. As this goes down, it will often go into the right main stem because of the way the anatomy is formed. Then we can pull that breathing tube back up a little bit and then ventilate the other lung. And so that's kind of an advanced technique, but just be aware that that's an option there. Putting a trach into a child with this condition is probably not extremely helpful because this would be below the level of that trach. And so, a trach is kind of an upper airway thing where this tends to sit a little bit lower than that. So asthma. Asthma is something that I want you to research fully on. This is a chronic inflammatory disorder that's episodic. So this can kind of wax and wane a little bit. It does limit airflow and it's got obstruction. So it causes your 3 tiers here, or your 3 steps of the stool, include inflammation, airway edema, and mucus secretions. So with that, we can also see some spasm of the smooth muscles of the bronchi and bronchioles. So treatment, of course, is going to be triggered at these things. So causes of inflammation, so taking that out of the picture and then treating inflammation in edema. So think about your steroids. So this can be oral steroids or inhaled steroids for a chronic type of situation, or IV steroids in an emergency situation. Looking at mucus secretions, so we can talk about cholinesterase inhibitors and those kind of things to try and dry them up a little bit. Spasm of the smooth muscles, so we can talk about some magnesium and getting that to relax. And then we can also talk about, with the inflammation, we can look at bronchodilators. So albuterol, which is a short-acting beta-2, is probably one of your lead medications that we give. Asthma can be triggered by many things, including hot, cold, exercise, hormonal changes, smoke exposure. Smoke exposure can be from cigarettes, from marijuana, from vaping, from wood-burning stoves to campfires, and even candles sometimes. So realize that when you ask about smoke exposure, it's not just cigarettes. Mold, cockroaches, dirt, dander, exercise-induced. So there's lots of different things that can cause asthma. If we can keep a book of it and they can figure out what some of their major triggers are, that's always a great thing. If it's allergens, then oftentimes we'll give like a Zyrtec or a Claritin or something like that, trying to prevent the body from ramping itself up and having those exacerbations. Patients will have an expiratory wheeze. You can click on this and hear what that sounds like. This little kiddo is a happy little wheezer, but the things I want you to aware of is that it is an expiratory noise and that they've got a prolonged expiratory phase, meaning that when they breathe out for a longer period of time. So on this is a link of a teenage boy in Australia, I believe, that's got asthma, and he's having an exacerbation that needs some emergency medical care, and you can kind of see how he walks through that. They're treating him with some albuterol, and then of course education afterwards. If you click here, this is the current asthma guidelines. It's about 72 pages. I know it seems long, but it really is the definitive care for people that have got asthma. And this will cover infants through adults, and it's a nice way to provide a guide for how do you label this. Is this an intermittent asthma? Is it a mild asthma, a moderate asthma, or severe asthma? And then as you go through there, you can use that characteristic for saying, okay, it's moderate for this age group. These are the meds that I should be using. So some people have critiqued it for being cookbook medicine, but I find it really handy to try and standardize this and to give you a background for what to treat and how to classify it and how to use the appropriate terms for this. So here are the quick guides for it. So looking at what meds for use in what situations. With asthmatics and people with asthma, they should still continue activities. So they need to exercise. Swimming is often a really good exercise for those with asthma. We can use steroids, as mentioned above, to kind of control some of the edema. Just think about the pros and cons for some of these things. When would we use oral versus IV versus inhaled? Think about all the side effects. IV and oral have got more systemic side effects. Inhaled steroids still have some side effects, such as thrush and height reduction of approximately 2 inches, depending on how much they're using this med. But there's definitely issues related to steroid use, and that's the systemic ones. You can think about moon face, buffalo hump, mood changes, increased appetite, decreased wound healing, decreased immunological responses, increase in sugars. So there's lots of bad things that go along with steroid use. And that's why we really try to minimize it, get them on a good care guideline, and put them on preventative meds such as inhaled corticosteroids or Singulair or something along those lines. Cystic fibrosis, this used to be predominantly just a pediatric issue. We are doing a better job of caring for these patients, and they're living longer. I've personally known a gentleman in his 50s, and so this is not just amongst kids. So you will see this in the adult world as well. This is the most common lethal genetic illness amongst white children. So basically you get the basic defect, which is genetic in nature, and it impacts the chlorine transport. So what you're seeing then is that you're going to get exocrine gland dysfunction, and along those lines, we're going to have issues with the respiratory system. So increased secretions, and often leading into bronchial pneumonias and some obstructive emphysema. We're going to see changes along that small intestine. And so one of the first signs of this might be that they have insipated meconium. So this is a delay of their first stool as a kid and not passing that meconium stool within the first 24 hours. So if they've got a delay in that, this is one of the things that we're really worried about. And this can actually lead into intestinal obstructions of the newborn and need surgical correction. We can also get issues with pancreatic ducts, causing degeneration of the pancreas, and so we can talk about malabsorption syndromes. We can talk about insulin production with this. We can also talk about the bile ducts and biliary cirrhosis and portal hypertension and all those fun things. Along with those bile ducts and the bile salts, we need those type of things to break down the fats. And so you're going to see that because of their diet and their influence on this, they're going to be on a multivitamin, especially supplementing the fat-soluble ones because we're having a hard time breaking down the fat. And so they need supplemental ADEK vitamins. Diagnosis. So initially we'll do a sweat chloride test, and basically we are just getting some sweat and seeing the concentration of the chloride in that. If that is done and confirmed, then we'll usually go on with genetic testing. There are, over 1,500 different mutations that can cause CF, but the delta F508 is the most common. So we can talk about the respiratory stuff as we talked about pneumonias, but realize that these patients tend to get different infections than what the normal population does. So we're going to see things such as Pseudomonas, and this Burkholder cepacia is kind of pathognomonic for CF, meaning that we don't see it in a lot of other groups besides CF. And so if the patient is positive for this, that might lead into a diagnosis of CF as well, and making sure that they wouldn't have it. Of course, we can see some of the more common things, Staph aureus, we can see H-flu, E. coli, Klebsiella, but oftentimes we're seeing Pseudomonas and the Burkholder cepacia. So treatment of this, of course, is preventing complications. So with this, we're using chest physical therapy, which are those vests that kind of shake. We can use albuterol to try and open up those lungs a little bit. We use Pulmozyme to break down the mucus, and so they can have an easier time coughing it up. If it's something that we can treat with antibiotics, of course we will. We work on their nutrition, having a good diet, and supplementing pancreatic enzymes, because once again those are impacted here. We talked about the vitamins before, especially ADEK. We still want to encourage activity and get them up and about, and we want to promote the best quality of life that they can have. Finally, on our last slide, talking about CPR and considerations in children. So with this is a good image of respiratory insufficiency. So the things I really want you to see in this picture would be the subcostal retractions, intercostal retractions, and supraclavicular retractions that this kid has. Also note the noises that this kid is making during this time, and the color and the activity level. So when you look at this kid, you can kind of tell that this child is not doing well. And I think he's just a few moments away from being intubated. Be aware that respiratory insufficiency can lead into respiratory distress, and respiratory distress is one of the major causes for respiratory failure, of course, and respiratory failure can then lead into cardiac failure. So for a full-blown asystolic event in children, often it is respiratory in nature, and then it progresses. For these type of situations, often our treatment is epinephrine. So if their heart rate is low or absent, epinephrine is your go-to med. And oftentimes we're doing that time and time again during a code situation. So every 3 to 5 minutes we'll be giving epi. So that's why I say epi, epi, epi. In pediatrics, if you're talking about a code and somebody asks you what meds to use, epi has got to be a strong contender for your choices. I know that you guys are all up to speed on your CPR, but here's just a brief reminder if you want to go there and review some stuff. As you get further on, here's PALS guidelines for this. So PALS is Pediatric Advanced Life Support versus ACLS, which is the Adult Cardiac Life Support. But it's great training, it's great guidelines on what to use for too fast of heart rate, too slow of heart rate, absent heart rate, PEA, all these different things. There is a link here for talking about a pediatric code. It is a little hokey, but it does lay out the steps in a very nice fashion for what to do, and who to call, and what are some of the things that you need to do. So, this is going to conclude this presentation, and this will be the last of the 3 series for respiratory dysfunction. If you have any questions, please contact me.